Hi everybody, my name is Carly Kind and I'm the director of the Ada Lovelace Institute. You're all here, so I assume you know that the Ada Lovelace Institute is a research institute based in the UK with a remit to ensure that data and AI work for people and society. And we're really pleased to have excellent speakers here joining us for the webinar today. Before we get going, and as people are still trickling in, I'll just remind you that no attendees will be visible or audible during the webinar, so you won't be able to speak to us, and we can't see you on this side of the panelists table. You can ask questions using the Q&A function at the bottom of your screen. Please submit these at any time during the webinar and we'll be synthesizing them and then pass them on to the panelists when we move into the Q&A part of the conversation. There is closed captioning available. If you click the closed captioning button at the bottom of the screen, we have a translator doing live closed captioning for us. And we're also taking a recording of this webinar, and that, along with a written summary, will be available on our website later today, hopefully. So thank you so much for joining our conversation today. No silver bullets. How can the UK government use technologies to transition out of the COVID lockdown while also protecting public health? The Ada Lovelace Institute is very honoured to be joined today by three speakers. Trish Greenhalgh, who's a professor of primary care health sciences at the University of Oxford. Yves-Alexandre de Montjoye, who's an assistant professor at Imperial College, and Simon McDougall, who's the executive director for technology and innovation at the Information Commissioner's Office. We asked Trish, Yves-Alexandre and Simon particularly to join us today because we're interested in having a cross-disciplinary conversation about the use of technology in the context of this crisis and making sure that voices from health, from the tech side and from data protection and legal are all represented in this conversation. And that's really an extension of the approach that the Ada Lovelace Institute takes with all of our research, and in particular, the approach that we took with a rapid evidence review that we published on Monday called Exit Through the App Store, in which we looked at different expert opinions on how different types of technologies might be used to ease the transition out of the crisis, and raised some of the legal, technical and social considerations that we need to be thinking about as we look to technology to supplement public health initiatives in the context of the coronavirus crisis. I hope many of you will have read that report. We are actually going to be publishing some short 2-page summaries of the report later today that are specifically geared to technology providers and developers, to Parliament and to policymakers. I think the kind of top line from that is encapsulated in the title for this webinar, which is No Silver Bullet. We think that there is a lot of technical limitations, but also societal considerations that need to be factored in when using technology to exit the crisis, and that an app alone won't be able to solve our problems and in fact may exacerbate them if not thought through properly. But you're here to hear the experts, so I will turn over to them. We're going to hear first from Trish, and I think my kind of provocation to Trish to kick us off would be, how, if at all, should the UK think about using digital technologies like contact tracing as part of the exit from this crisis?
That's a really interesting one. I mean, I would say, first of all, it's not just about that contact tracing app. You know, digital technologies have got a huge potential. We're now seeing apparently 93% of all GP patient consultations happening either by telephone or by video, whereas fewer than 1% did 2 months ago. So there's been this massive transformation of primary healthcare. So there's loads and loads of ways that digital tech is going to help us run a service that is perhaps slightly less in your face physically, and allow people to contact their doctors, nurses, other health professionals. So putting that aside, the real sort of hot question is, what on earth is this app? And is it going to help? You know, the Secretary of State for Health, Matt Hancock, very early on took on the nickname Matt the App. And the reason why I did that is he was very keen on new technologies, and particularly things like apps that might be able to help transform the way we deliver services and also the way we care for ourselves. Now, although I'm not opposed to tech, in fact, I'm very supportive of technological solutions, my worry is something called technological determinism. In other words, introducing a technology, and particularly an app, and thinking that that is going to cause a particular change in the way people live their lives, in the way we deliver healthcare. And of course, it doesn't do that. The technology at best will be a tool. So let's just talk about this app as part of what we might call an ensemble of care. I'm remembering back 30 years to when I was a relatively junior doctor, and one of the things I did to sort of help pay the mortgage was a bit of sexual health. I was never, you know, an expert in that, but, you know, the contact tracing there is you sit someone down and then you'd very discreetly and very professionally, wearing your white coat, would say, well, could you please give me a list of the people you've slept with in the last however many weeks? And of course, that was actually relatively easy because you can remember usually who you've actually been to bed with. The problem with COVID is this is a completely different infection. This is who have you been in a shopping queue with. Some of the interesting case studies coming out of restaurants where it's the people sitting near the air conditioning vents. So it's not that they were next to someone at the next table, but that they were at the other side of the restaurant. But because of the way the air conditioning was flowing, they were infected from the contagion. So what we've got is something that's clinically a very different disease from the conditions that we were using contact tracing for. But let's just go into the technical aspects of that app. As I understand it, it works by your smartphone becoming aware that someone else's smartphone is within vicinity, and then it sends a message. Now, in order to do that, you've got to have a smartphone and you've got to have downloaded the app onto it, and the other person has as well. And let's say, for example, that 50% of us would have downloaded that app. But of course, that means that I've only got a 50% chance of having that app on my phone. And the other person I'm in contact with also has a 50% chance, which means there's only a 25% chance. If half of us have the app, there's only a 25% chance that we've got a match there. And what that means is, I think a very high proportion of the public would need to have that app in order for the contact tracing to cover a reasonable proportion of the population. And when you go into, you know, citizen mode, you think, well, would I personally download this app? I asked my husband and my kids last night, you know, I'm coming on this webinar, would you want one of these things? And they all said, no, you know, why would I want to be tracked? And the answer is, of course, for the greater public good. Now, yesterday, there was a paper published in the Journal of the American Medical Association. I've put the link in the chat, actually. And the way South Korea did this was they used data from mobile phone carriers, immigration service, police, credit card companies, public transit companies, government agencies, health insurance agencies, and hospitals to get all sorts of data on people in order to feed into the surveillance. And actually, this paper is written by people from South Korea saying, and we think, although it worked, my goodness, it was a heavy price to pay in terms of privacy. And that's from South Korea. And I think the question, which I think others are going to be addressing in this webinar, is would citizens accept this? Because it isn't going to work medically unless, I think, a very high proportion download that app. So I think I've probably spoken enough now, Carly. I'm quite happy to come back afterwards.
No, that's great, Trish. Thank you so much. Can I ask you just to supplement a little bit what you said on the question of, we spoke a little bit about this yesterday, and I think it might be interesting for this audience. We talked about assuming people do download the app and use it, and some of those trust questions are answered, and I'm sure Yves-Alexandre and Simon will speak to those. From a care perspective, how do we think about how effective a technology can be in instructing somebody how to take better care of themselves or stay home and quarantine? Is there understanding research we can draw from to think about how an app might be effective in that respect?
Yeah, so we were talking about this yesterday, and I was drawing parallels with some rather old-fashioned technologies now. There's one called Florence, which is a very simple text-based messaging system where you can manage or help someone manage their chronic conditions, so blood pressure, depression, diabetes. They've done it for breastfeeding support, actually, that kind of thing. So whatever the condition, and then every day the person gets a little message which is sent by some kind of bot, and then they have to put some data in. So for example, you know, the level of blood pressure 120/80, something like that, and then they get a message back saying, yes, just to confirm your blood pressure seems fine. And you know, with the depression, they would be answering yes or no to, you know, how they feel. Now, rather surprisingly, the evaluations of those technologies show that people feel very supported and very cared for. And what's more, they kind of anthropomorphize this bot. They say Florence, just like Florence Nightingale, it's a nurse looking after me, all that kind of, even though they know very well it's not a nurse, it's a bot. And that kind of data suggests that if people are getting personalized messages which they don't find patronizing, which they find supportive and helping them based on data they have provided, it just might work. On the other hand, and I think I may have shared this yesterday, I was accidentally put on the shielded list for COVID-19 for no good reason. You know, someone had misallocated an illness I'd had and made it much more serious than it actually was. So I, for a while, got all those messages from the government about that they were sending to the people on the shielded list. And they were quite extraordinary. I got one which said, don't forget to eat and drink. Now, hang on a minute, why would the government want to tell me how to eat? And the thing about those messages was they weren't personalized, they weren't tailored. Someone had just put me in this great category of shielded and then assumed that I was stupid and also rather sort of passive and needed to be told how to live my life. And I was quite offended. I mean, I wasn't offended by them, but I found them rather funny. And I certainly didn't obey any of them. So I think the difference between a tailored message that takes account of what data is actually relevant to that person and also to their contacts is going to have more of an effect than just some blanket instruction of, you know, go and shut yourself at home now for the next 2 weeks or whatever it's going to say, which I don't think is going to work. But I'm sure others on this webinar have got more to say about that.
That's really useful. Thanks, Trish. And so I think really thinking through, aside from all the privacy things which we'll come to, the kind of user interface, user design and impacts on behavior is actually a really important piece of the puzzle to thinking about how effective this app might be. Okay, let's turn on to Yves-Alexandre, who last week or the week before wrote a very interesting white paper asking some privacy questions around the use of contact tracing app. And it would be great if we could touch on some of those and also hear your opinion or your thoughts on what we know about the current NHS app and how it might square up against some of the questions that you've been asking.
Yeah, I mean, basically, I think maybe I was thinking that I would touch upon 2 points. I think the first one is really the more general use of data against this crisis and what we've seen so far, and then turn to contact tracing apps. I think the first one is really, and this is something that doesn't get discussed much compared to the contact tracing, but a lot of things have been moving, a lot of data have been put together in the fight against the crisis. And I think we've seen quite a lot of announcement of centralized databases being created to help and inform the fight against the virus. And why I think, you know, there is a good reason to do this. I think I've been a bit worried of the lack of transparency of what has been happening. I think we've seen quite a lot of announcement of basically, like, you know, some creation of dashboards and centralized databases, and then the reassurances we were given in terms of what this data is going to be used for and the way it's going to be treated was limited, and some of it not technically accurate. in practice, like, you know, there were discussions of this database, and literally the description was, the reference was, well, don't worry, this data is anonymous, and then the description of what was being put in place is the literal definition of pseudonymization, meaning data that, you know, does not contain your name or your phone number or direct identifier, but when linked with other information that someone might know about you, including your partner, might very well be re-identifiable. I think what this means is mostly that, you know, like other precautions are being taken and other, like, you know, risk mitigation strategies are being put in place to ensure that this pseudonymous data is used anonymously. But there was, you know, very little that was disclosed on how this data was collected, used, and what mechanisms were put in place. And I think it's certainly very important to use everything we have, including data, but I think it's also very important to be able to understand what are the risks. I think we published last year, I think, a paper showing how easy it is to re-identify data like medical data. And, you know, showed, for example, that, you know, 15 demographics, so me knowing 15 demographic attributes about you, like whether you're married or not, gender, and other kind of information, is sufficient to uniquely identify someone in a database 99.98% of the time. So that gives you a sense of, you know, the potential risk with pseudonymized data. And again, not saying that it shouldn't be done and that there's no good solution to use data anonymously, but I think there's a need for transparency. On contact tracing, basically, I think I'm on the one hand positive because I think there was very much a fear at the beginning of you know, like kind of the nightmare scenario of apps being launched and basically, you know, like collecting everything they can get their hands on for you know, to do contact tracing. I think thanks to, you know, like a quick reaction by both the privacy community and Google and Apple, I think hopefully we're out of the bush, in a sense, like, you know, like this nightmare scenario will not materialize, and I think that's very good, and it really emphasizes that there are ways to do contact tracing that are compatible with our data protection laws and liberal democracies. That being said, I think there's still a lot of questions and prioritization that is being made regarding the development of those apps. And, you know, like the fact that it's encrypted, the fact that it doesn't contain location data, or the fact that it's centralized or decentralized model is not really sufficient to be able to assess the robustness of the system and the prioritization that has been made. I think we put together, like, you know, a list of privacy questions that we would like to see answer regarding the privacy of contact tracing apps. And I think here again, like there was quite a lack of transparency in what we've heard so far, beyond, you know, reassurances basically that, you know, like this would be done in a privacy friendly and ethical manner. And I'm absolutely sympathetic to the need and some of the, you know, like requirement from a public health perspective, but I do think that this is a debate that we need to have in the open, and for this we need to know more about what is currently being planned.
In that vein, is it possible at this stage to talk about what the trade-offs might be between a decentralized and centralized system? We hear some, you know, we hear some high-level claims being made in the media, for example, that the Google and Apple decentralized system, while incredibly privacy-preserving on the one hand, might prevent some of the functionality that national health or public health services want. So there's been some reporting about the French government coming out and saying that Google and Apple doesn't allow them the functionality they need. Is it the case that that's a straight kind of zero-sum game when it comes to privacy on the one hand and functionality on the other, or do you feel that it's possible to resolve those questions?
So yes, we can have those discussions. The thing is, it's difficult to have them like, you know, without a bit more details of what is being currently considered. I think from an academic perspective, there have been a lot of discussion between basically a centralized Robert protocol and a decentralized Google Apple protocol. The thing is, basically, it is not a zero-sum game, and it is not quote unquote unidimensional, meaning that it's not like, one is not necessarily more or less privacy preserving than the other. I think, we have, from a technical perspective, privacy is multidimensional. It's not like, it's not one thing and it's slightly more, slightly less, right? There's a range of attacks and potential risk and mitigation strategies. And then the protocol every protocol has pro and con, and is more or less protective against a specific attack. So that's why, instead of trade-off, to me, it's much more a question, even purely on the privacy side, of what do you prioritize? What do you think is the most likely? What are we mostly worried about? Are we mostly worried about how much data gets sent to the centralized server? Are we mostly worried about making sure that I learn the information that I've been in contact with someone who's infected without the government knowing that I'm potentially at risk? Or are we worried about basically me finding out who infected me or one of my grandparents? And so those are, like, for example, three of kind of the dimension potentially for privacy. And then, as you said, right, indeed, there is the utility side of things of, like, how good is it? How much information does it give? And also, which kind of control does it give health authority? I think the French argument is basically that the decentralized protocol is basically making them blind to what is happening, including many people are going to get a notification on their phone basically telling them you've been infected, you need to go to a hospital to get tested, and therefore they would rather trade a little bit on privacy for one specific dimension in favor of a little bit more control. And again, I'm not saying that one is necessarily better than the other, but I think we need to have, this is exactly the kind of discussions that we need to have, and then show what are the prioritization and choices that have been made.
Thank you. I like that framing a lot, privacy not being unidimensional. That leads us, I think, really well to Simon. And if I can turn over to you now, Simon, from the ICO's perspective, how are you looking at these issues around the contact tracing app? And also, if you have time to address, I'm interested to know what you think about the process that should feed into thinking about some of the questions that Yves raised. And this ties in with a question that's asked by Andrew Eccles from the University of Strathclyde in the Q&A, which is, given that these decisions are being made at pace in a context of a lot of pressure to find solutions to complex problems, what is the process that allows us to think through the ethical, social, legal impact? And I know data protection is a kind of risk-based framework. It is quite process-driven. So if you can talk to some of that, that would be useful.
No worries at all. And I'll address that question towards the end. But Carly, keep me honest, because I've meandered away from the question. Pull me back onto it. So I think it's worth starting off by just setting the mood music for where the ICO has positioned itself in this crisis. I think we've worked hard to convey that we're trying to be pragmatic, proactive. We've communicated points around our regulatory posture, and we've effectively said that we understand in this time of national crisis that decisions have to be made, and there are points around public interests and individuals' vital interests, which have to be balanced against, the everyday privacy rights. Privacy is not an absolute right. We are living in extraordinary times where we are all agreeing to limit a number of our rights. The fact that we're having this as a Zoom conference is because we're all agreeing to restrict our freedom of movement for a small period of time. And privacy is part of that equation. And I think we've also realised through these last few weeks quite how reliant we are on technology and on data processing for pretty much every part of our world, whether it's getting goods delivered to our house, or the arts that we're consuming, or the content we're making with other human beings, or the work that we're doing. And we're trying to strike a line where we're not throwing out the baby with the bathwater, and we are very keen to ensure that law and regulation continues to be complied with, whilst appreciating this is a national emergency, and very often people are making decisions which, where time is critical, and a delay of a day means that X number of people will die if something doesn't happen. it's just, it's often as simple, sadly, as that. And the way we're dealing with that internally is we're dealing with all manner of questions, ranging from local authorities wanting to know about what data they can share on vulnerability, through to indeed questions around things like the NHSX app. And we're also trying to think forward and understand what larger, longer term questions we have to deal with. I know that I think we're going to have an event with you, possibly in early May, Carly, jointly, to kind of cover some of those discussions. So that's where we are. In terms of contact tracing, we've tried to be proactive around explaining what we think good practice looks like, and actually get off the fence. It's very easy for regulators, I think, to either wait until they're shocked and appalled by a particular situation and throw their hands up in the air and say so, or be quite Sphinx-like and say nothing until throughout the process. So last week we produced 2 documents at the end of the week. One was a blog from Elizabeth Denham, the Commissioner, talking around contact tracing, location tracking, and talking about some of the principles that we thought were important around data minimization, decentralization where possible, purpose limitation, transparency, and also an opinion. Only the second formal opinion we produced, which was specifically on the Apple-Google API. And I think that's important because we wanted to be able to say something constructive about something which we thought on the whole was aligned with the principles of privacy by design, data protection by design and default. And so we worked quite intensively over that week after Easter to actually get to a stage where we could provide an analysis of that. I completely agree with Trish's earlier points that technology is one component of a very large solution here, and contact tracing, I think any contact tracing app has to be complementary to human contact tracing as well. But in terms of what we thought as overall a helpful initiative by 2 large organisations working together more closely than they normally do, we wanted to be forward in saying that we thought that overall this was a good thing. I'd encourage people to look at both the blog and the opinion there. I'll flag it just because it only came out a couple of hours ago. I'd also encourage people to look at Matthew Gould being the CEO of NHSX. He produced a new blog on the contact tracing app a couple of hours ago, which spoke to a whole range of points around this area, and again alludes to many of the themes that we think are important in this area in terms of data minimization, purpose limitation, and the like. I would say that one thing I would say, and this is where I differ slightly from some of the points that came out in the Ada Lovelace rapid response. Overall, I thought was a fantastic document, just the kind of thing that moves on the debate, very helpful. Our experience so far is that the data protection regulations, GDPR, Data Protection Act 2018, our UK regulatory framework, has held up pretty well so far. We haven't had to lift bits of the law or waive it. It is designed to handle a crisis like this, and that means that there are areas of regulatory discretion, areas where there's public interest exemptions, etc. And we're thinking it's flexing pretty well. And I do think it's a good test of this regulation, and we can go back to the good principles around fairness, security, information rights, data retention. These things are all very, very, very relevant to hold up. I do think that one thing we'll come back to as we go through this is the need to, as I speak to the question that's raised, the need to do what we can do up front at speed. And I'd point to data protection impact assessments to being a very critical tool here, and one which we often point to. But then also accepting that when this all gets into a more manageable situation, I don't want to say gets back to normal, because I'm not sure there is going to be a normal for a very long time. But when we get past this initial crisis phase, how do we go and clean up? And I think having retrospective audits and looking back and reassessing where we are in terms of data retention, etc., those kind of points are critical. We do have to accept that everyone is moving fast. And that means that there will be some mistakes made, and there'll be some assumptions made which don't hold up and don't stand up to the test of time, and we need to accept that risk. But as we do have slightly more time, how do we go back and say, right, whether it's the ICO doing an audit, or an internal function, or third parties, or civil society challenging what is going on within government, whatever the situation is, we need to go back and say, okay, now we know what we know, how do we get to a new normal, and how do we sometimes roll back what is happening? And sometimes how do we accept, as Trish was saying right at the start, that the new normal is better? We have achieved things through information, through data sharing within the health sector, which people have been trying to achieve for the last 20 years. And it's great that we've now made some progress there. We don't want to go back exactly to the old days. But I'll finish on one point, and I think this is the key point for me in terms of the success of any future contact tracing app. And it talks to the points that Yves-Alexandre and Trish have both made. Any app has to have a really high level of take-up to have a chance of being successful. And there are issues around exclusion and how many people can actually use any kind of app in terms of smartphones they have and the technology they have available to them. And we can only get even halfway to having the level of take-up we need if there is a huge level of public trust in the app. And that level of trust can only come if there is a real coalition of voices, and it will have to be different voices because different people in the community trust different voices, saying they think that the app is okay. So this app, whatever it looks like, has to bring everyone along with them. It has to have the transparency, it has to have the engagement, and it has to have regulators and civil society and experts and academics all saying, actually, we think this is a workable solution. And that's, I think, why this debate today is very important, and why the work that NHSX is doing to explain what it's doing through the blog, through its various accountability mechanisms, are critical. Because if we don't have trust, we may as well just give up on this whole thing and move on to a different idea.
That's great. Thank you, Simon. I've got some questions for you, but I want to go quickly to Trish because I could see you nodding along there on the trust point of view. And I wondered I assume that getting GPs and primary healthcare professionals to endorse the app as well will be key to building public trust. I'm sure most people trust their doctors most of all. What do you think medical professionals need to know or see about this type of app before they would?
Yeah, I mean, I think there's the work I've done on trust. I would say there's at least two different kinds of trust, possibly three different kinds of trust. First of all, there's the trust you have in someone who you know them, you've had a continuity of care relationship, and you know that they're making decisions in your best interest, that kind of trust, and there is this thing that if someone's been your family doctor for years and years, you trust them more than this person that you've only just met type thing. That's the first set of trust. The next kind of trust I think is relevant is trust in the system, trust in, for example, the NHS, for example, or the welfare state, so that's a different kind of trust, and that's a trust in the governance and in the procedures and in, that kind of thing. It's not a personal thing, it's a trust in the system. And then there's something that we might call hegemonic trust, that is we trust because we can't not trust, if you know what I mean. So I've got an elderly relative who the decisions of that person's doctor sometimes surprise me, but this elderly relative says, oh, no, he's the doctor, you've got to trust the doctor. Not because he's doing particularly well, because somehow she can't not trust the doctor because she's sort of been almost brainwashed to trust doctors. Now, I think we have to sort of unpack what kind of trust we've got, because if I were a GP and I said to my patients, you're going to have to trust this app, the fact that they trust me doesn't necessarily mean they're going to trust the system. On the other hand, if in relation to, say, patient data that I was the custodian of, and I would say to the patient, look, I'm not going to release your data unless there's a very good reason, for example, and I'll protect your privacy. What they're doing is trusting me personally to protect them from the system asking for it. But this is a different situation where we're saying, would be telling my patient to download this app, and I'd also have to say to them, look, I cannot control what they're doing with it. So although you're right that I think family doctors, and not just family doctors, but you know, anybody that the patient has a long-standing trusting relationship with might help there. You know, the local MP, for example, might advocate for this. Nevertheless, those individuals are not going to be able to say, I will be the kind of interface between your data and the system, because that's not what you're asking them to do. You're asking them to basically give their data directly to the system. And so then, I mean, Yves-Alexandre was talking brilliantly about it. You know, it is about what kind of safeguards are there. And I would just say, in technologies, there is a tension between accessibility of data and protection of privacy. So you always have to trade those off against each other. You know, for example, if you're going to have 5 different passwords to get into a system, data is protected much more, but my goodness, it's not very accessible, and vice versa. And so I think we need to manage that tension. There is no way we're going to resolve it.
Thank you. Accessibility has come up a lot in the questions as well, and also the impact on vulnerable groups, those that are excluded from technology, etc. There is a couple of questions directly that I will address. Yves-Alexandre, there's a question from Baroness Brinton in the House of Lords saying, did the statement that Lord Bethell made yesterday in the House of Lords provide any reassurance, which is about the fact that the NHS app will use latent, not overt Bluetooth? I don't know if you can speak to that directly. I'll leave it with you for a second, because I've also got some direct questions for Simon, so I'll go to those and then I'll come back to you, Alexandra. So there's a question about whether the ICO has signed off a DPIA for the NHSX app, and if so, will they publish that to raise, to kind of address some of the transparency concerns that Yves-Alexandre raised. And there's also a question about whether the ICO has any views on the data sharing arrangements between the NHS and third parties like Google and Palantir. Yves-Alexandre, do you want to come in on the Bluetooth question? And did I sufficiently explain what the question was asking?
No, could you repeat? So basically,
sorry, so the
at least from what I understood was like,
yeah,
it's using Bluetooth and not location.
Yeah, so apparently apparently Lord Bethell said yesterday, the type of Bluetooth we are using is the latent, not the overt Bluetooth. Data is not carried in the same way as in overt Bluetooth.
I think what they're referring to is the use of, and Simon might jump in, the use of ephemeral IDs instead of like, you know, like a persistent identifier going with your device.
Right.
Again, I mean, this is some information, and again, I think I do agree with Simon that it is good. Like, you know, we have seen a little bit of a willingness to discuss this in the open. The big issue from a privacy perspective is that you need to look at the whole system, right? Unless you can see the code and see the whole system, it's extremely difficult to actually have an informed debate on what Trish was mentioning, either the trade-offs or the prioritization. It's like, you know, it's to make try an analogy. It's basically like, you know, like privacy is like security. It's like, you know, your home is safe if, like, you know, every single door is properly locked. If, like, you know, 4 of them are properly locked, but one of them is open, someone will be able to enter. And so I think it is good to have this discussion, and I think it is, you know, I applaud NHSX for like, you know, showing a little bit of transparency on what they're thinking. But I think, like, you know, I really hope that we can have a more informed debate and actually look at the protocol and actually look at the code before the app is being launched. The mere fact that it's only using Bluetooth is not sufficient. I mean, we had an attack actually that we proposed, I think 2 years ago, showing that basically with Bluetooth, the proximity location, if I could get a couple of phones basically to install a modified or another app, basically I could basically monitor who is close to me, as well as my own location, and then be able to monitor the location of people at large scale. And that's actually a very effective attack. I think it's a very, like, you know, very rough, like, you know, back of the envelope estimate, but basically, like, you know, 1% of the phone in London having this compromised app installed would allow me to monitor the location of over, like, you know, close to 50% of the population on an hourly basis. And again, I'm not saying that, like, you know, I really hope that this will not be possible with good apps, but this just gives you a sense of the potential risk, and the fact that Bluetooth alone is and not location is not enough. We need to see the protocol. We need to see the code ahead of the launch, enough of the launch.
That's great. Thank you so much, Simon.
So if I build on that point for a second, and then I'll address the questions. I think. Yeah, we were quite clear in our opinion on the Apple Google API that we recognise it was very strongly aligned with the DP3T protocol, and whilst there's obviously already a wealth of material out there about the DP3T protocol, you know, we were, you know, where it aligned with the work on the Apple API, we were very supportive of it, and both those initiatives. Work on low energy Bluetooth, ephemeral identifiers, and effectively enabling a way of proximity reporting which doesn't have a centralized database at its core, and is really looking to use the technology layer to provide a level of assurance that there is no kind of centralized location tracking going on. One thing I think to note with all of these initiatives is, and Apple and Google have been clear in this themselves, is what they're doing is building you know, a particular utility to enable a particular kind of app to work. That doesn't stop any public health authority or government building lots more functionality into their app, including possibly using other aspects of a mobile device, including location tracking or asking you basic questions or assigning other identifiers to it that can work alongside the API. All the API is doing is enabling the Bluetooth on the device to be used in a particularly privacy preserving way. So we just cause something, if somebody comes out and says the app, and this is one of our concerns in the opinion, if someone comes out and says our app runs on the Apple Google API or our app follows DP3T, they might have other functionality which is problematic, or depending how you look at it, it might offer lots of, you know, utility for fighting the pandemic. So that's that point there, but yeah, very much agree with the other points made. I should say, in terms of these questions around DPIAs and our, you know, what we see of data sharing within government, I need to be clear on kind of our role in some of this. So the way it works under GDPR and UK Data Protection Act 2018 is that data controllers have responsibility for their compliance, and they have to take steps to make sure they have the right resources allocated to being compliant and that they form a view around their compliance. And so the buck stops with them in that respect. And then there are ways they can engage with the ICO if and when that they want to. So if they think their data protection, if they think their processing going on, or planned processing, I should say, which is high risk, and they don't have the right, and they think they don't have the right controls in place, they can bring their DPIA to us for prior consultation. So we don't need to sign off DPIAs per se, and we don't need to intervene on every individual piece of processing out there. That said, we absolutely have been consulted by NHSX on aspects of what's going on with the contact tracing app, and with many parts of government on other initiatives. That's not the same as us endorsing or signing off on detailed plans, but we have been asked our views at points and fed back. And I think everyone here is taking this as read, but I'll say it because I think it deserves saying. We have seen just a huge number of people from across government doing, you know, putting in Herculean amounts of efforts to kind of move quickly on these things. And I personally have been struck, as somebody who's been in privacy for 20 years, at how much privacy is being considered along the way. I can remember the old days when the data protection officer would just get a phone call at 4:30 on a Friday, getting told someone's going live on Monday, and they had to sign it off in half an hour. That's not the case here. These things are being considered seriously. And at the same time, there are payoffs along the way. Again, I think NHSX is moving very quickly on this, but it has committed to be publishing both its key security and privacy designs along with the source code for the app, so that privacy experts can crawl all over it. I think that's to be welcomed. And it is trying to utilize both stakeholders such as the National Data Guardians Panel, the CDEI, and developing its own ethics advisory boards to kind of have some mechanisms in place. So there is stuff, it is all moving at speed, but a lot of the things that we want to see that, you know, if they weren't there, we would be hollering for it. A lot of those things are being put in place, which is to be welcomed.
That's great. Thank you, Simon. We have a lot more questions coming through, but I think I'm going to, in the interest of respecting everyone's time, cut it off there. Thank you, almost 250 people, for staying with us for so long. Thank you, Trish, Yves-Alexandre, and Simon for that. And I think this shows, just also on the basis of the questions in the Q&A, there's a real hunger for more information actually on what's under contemplation. I agree with you, Simon, there's been some great initiatives so far on the part of NHSX, and it would be great to hear more about those. Ada hopes to hold another webinar around this time next week, maybe with more of an international comparative approach, looking at what's happening in places like Singapore and Australia. So you will hear more from us on that. But in the meantime, thank you so much for your time. We appreciate it all, and take care of yourselves.